The next time you're assessing range of motion and you find that your patient or client has a tight muscle, I want you to stop and ask yourself this question. Is this person in front of me physiologically tight or positionally tight? Now, when I'm referencing physiological tightness, I'm thinking that there's actual changes within the tissue that causes it to be in a shortened position. In addition, there could be some sort of neurological component in there that's creating that stiffness. When I'm talking about positional tightness, I am asking myself, is the way that this person postures and holds their structure creating limitation in their range of motion? Now, to understand the positional aspect better, we can look at some of the more obvious examples that you might already be aware of. If we go in a rounded over position, the thoracic spine is going into flexion, the pelvis is going to a posterior pelvic tilt. We know that this is automatically going to decrease shoulder flexion compared to more of an upright posture. We can see another example at the pelvis, and this is when we turn the pelvis to one side and we raise our leg like we're doing a straight leg raise. When we turn, the side that is turning towards it is going to have increased motion. Then when we switch to the other side, and now we are shifted to the opposite side, we now are going to see the opposite. The side that you are shifting towards has more range of motion compared to the other. So a lot of times our patients come in and they are not in a good position. And this is going to have negative consequences on their range of motion. The biggest risk that we run into when we blindly stretch is that we actually strengthen our patient or client's dysfunction. For example, if you're working with a patient or a client and they come in with an extension-based pattern, so they have an anterior pelvic tilt, they have a wide infrasternal angle, their ribs are up, and they have limited right shoulder internal rotation. You can really choose two paths. The blind stretching path is going to give this patient or client a sleeper stretch to try to improve internal rotation. If they succeed, they most likely started to wear out that joint a little bit and put a little bit too much stress on that capsule to gain a short-term internal rotation range of motion. Conversely, when you start to realize that that patient has poor internal rotation on that right side because they're in a poor pattern, then you realize what I need to do is actually get the rib cage and the pelvis in a better position. And when I do that, it automatically clears up the shoulder. Now, to understand that, think of a house. The rib cage, the pelvis, this is the foundation of the human body. The shoulder and the limbs are the first and second floor. So if you have a problem on the second floor and you only fix the second floor, but in reality, you truly have a foundational problem, the second floor problem will keep coming back because the foundation is really the source of the problem. So going back to our limited internal rotation, when we start to get that rib cage back, when we start to get the rib cage more movable, pliable, variable, the shoulder is always going to favorably respond. This is why you can do 4 breaths and improve internal rotation of that shoulder without even touching the shoulder. This works because we are affecting how that shoulder is sitting in that socket because we're pulling the rib cage and moving the pelvis into a more optimal position. So the solution to this positional tightness is first increasing awareness. We have to be aware that the patient or client that we are looking at has a certain pattern and posture which is going to create expectations. Remember our example in the beginning. If you're in more of a rounded pattern or posture, you're going to have limited shoulder flexion. Conversely, if you're in more of an extended pattern or posture, you're going to have increased shoulder flexion. Why? Because the rib cage and the pelvis are dictating where the shoulder is going. The second solution is to better align the rib cage and the pelvis. Like we talked about, this is the foundation of the human body. We need to have a good, strong, optimal foundation to allow good and pain-free movement to occur. So we're going to work on stacking the rib cage on top of the pelvis. We need to increase movement variability for our patients so that they're not stuck on too much of that flexion side. They're not stuck on too much of that extension side, but they can move variably in between each pattern or posture. So like we said, we need to first increase awareness. So for your patients and clients that have a flared rib cage, an anterior pelvic tilt at the pelvis, throw them in a side lying position. Let them really understand how to move that pelvis, how to get their rib cage back through exhalation, and how to stack that in a way that they can do it in a controlled manner. For someone that is in more of a flex posture, in a posterior pelvic tilt, start to put them in more of a supine or a hook lying position so they can feel a little bit of an anterior pelvic tilt bias and a little bit of extension to get that rib cage back up. The goal here is not going to extreme on the posterior or anterior pelvic tilt. Instead, it's coaching and cueing your patient enough so they can get to where they have a better position. What I mean by that is some people are going to need to go in a bigger posterior direction. Some are going to need to go in a bigger anterior direction. It really just depends on their overall pattern. It's up to you as the coach and clinician to get them to the place where they need to be. Once you do this, you are setting yourself up for them to have more range of motion, to move better, and to move pain-free because you're putting the rib cage and the pelvis in an optimal position, which is going to give them the range of motion that they probably didn't have at the beginning of the session.